Okay, so now we're going to move on to the largely the fat-soluble vitamins. Except for, we're going to be doing A, C, D, E, and K. Which one is not a fat-soluble vitamin? C, yeah, ascorbic acid. So the rest are all fat-soluble. That's kind of why I grouped these here, try to group the B vitamins together, because those are all water-soluble. So the first one is vitamin A. Now again, there's a lot of biochemistry on here, and I'm going to boil it down to the bare essentials of what you need for vitamins. So vitamin A, beta-carotene, yellow or orange. Those are the target colors, right? Anything yellow or orange is high in beta-carotene concentration. Why are you focused on yellow and orange as opposed to green? What gives the color?
The carrot section.
Is
How it
It's those alternating double
the carotene.
yeah, it's beta-carotene, gives the color. We've got some biochemistry mojo down here. It's these conjugated alternating double bonds. We've got a resonance structure that gives it color. Now, isn't that important to tell your patients? You need to focus on yellow because of these conjugated double bonds, and then you know you're getting your vitamin A complex. Okay, that's my chemistry thrown in there. So beta-carotene is simply a dimeric structure of vitamin A. So what we need to do is we take our beta-carotene and we're going to cut this molecule in half. And what we get are two molecules of vitamin A. Now, when we break this in half, when we cut this molecule in half, what we're going to get is two molecules of retinaldehyde. Now, an aldehyde, the end, of course, is the aldehyde structure. Aldehydes are very reactive, so we have to be very cautious on how this aldehyde circulates. So what we're going to do is we're going to convert this aldehyde to an alcohol, and that is retinol. And retinol is what is transported in the circulation. Retinol is transported because alcohols are very innocuous. They're not reactive very much, and it's an easy way to protect this molecule from any type of potential damage it could be making with the aldehyde structure. Now, the other form of retinaldehyde can be converted into retinoic acid. Here's the end of retinoic acid. It's an acid. So again, this is something we don't want in the bloodstream. It can throw off our pH. And so what we're going to do is we're going to convert the aldehyde and retinoic acids into retinol for transportation in the circulation. So that's primarily the difference between these functional groups on the end of vitamin A. So how does this system work in circulation? So here's our beta-carotene. I have here beta-carotene bile acids. So what is this about? What is the connection between beta-carotene and bile acids? Emulsify the fats. Yeah, so the beta-carotene is a very hydrophobic lipophilic structure, and so it's going to be fat soluble. And so the bile salts will be involved in emulsification, so the beta-carotene is essentially going to be piggybacking on the bile salts and fats for uptake into the intestinal enterocytes. Then we have our processing of the beta-carotene, basically to cut it in half to make our two aldehyde structures of retinaldehyde. And then we are going to convert the retinaldehyde into the retinol structure, and then the retinol is bound with a fatty acid, fatty acyl ester. And then again, remember it's fat soluble, so we're going to package this into a chylomicron. And the chylomicron will be the carrier for the retinol structure. Now you'll see here, we'll talk about this in a second, there's a small amount, it's dashed line here, a small amount of the retinaldehyde that is converted into retinoic acid in the intestinal cell. We'll see in a minute what retinoic acid is important for. So again, the chylomicron goes in our circulation, we get our LPL processing, removing our triglycerides. Those remnants are taken up by the hepatocyte, and they're primarily stored in the hepatocyte. Some storage in the stellate cell, that's that Ito cell, but primarily in the hepatocyte. It's primarily stored as retinol, the alcohol form. And again, because if you're going to store something, you want to make sure it's not reactive in a pathological way. So instead of converting this back to the retinaldehyde form, we're going to leave it in the retinol form. Now here's our RBP for retinol binding protein. This is the major protein. Transthyretin, I do not believe is the major protein that carries retinol. RBP is the major protein. And so we need a carrier protein, primarily because, again, it's a lipophilic molecule. We use the chylomicron to deliver it to the hepatocyte, but when the hepatocyte releases it from storage, it's going to use the binding protein. The binding protein is taken up by extrahepatic cells, most cells that need it. It's going to be in the alcohol form, and then depending on the tissue and the tissues needed, it can either be converted into the aldehyde form or it can be used and stored for a period of time in the fatty acyl form. The final form it can be converted in is to the acid form. So the conversion of the carrying form of retinol to either retinaldehyde or retinoic acid is going to be tissue dependent on what that tissue needs. Now, here's a good example of a tissue need. So we've got our retinol being converted into aldehyde to retinoic acid inside our cell. Here's the nucleus, the retinoic acid going into the nucleus. And retinoic acid is going to serve as a binding factor, a cofactor for transcription factor. So RAR is the retinoic acid receptor. RXR is the retinoic X receptor. So retinoic acid is going to be binding to these transcription factors, and when it binds, it becomes an active transcription factor, and now it can bind down to the promoter, which is the RAR element, retinoic acid receptor element. So this is our promoter sequence. And this is going to be generating protein, RNA and protein, from very specific genes, proliferation-related genes, differentiation genes. So you can imagine, is retinoic acid important in development? Big time. Big time in development, because you're generating all of those proteins that are directing differentiation for certain tissues. Now you're going to have some patients with aging skin come to you, and they're going to talk to you about, I'm taking some over-the-counter medication, this cream, and it has retinol in it. And it's supposed to be really good for skin and regeneration and skin firmness. Here's the method, here's the rationale for this type of over-the-counter treatment. The retinol is converted into retinoic acid, and what you're doing is you're increasing the potential of proliferation of skin cells. It also enhances UV DNA damage. Skin, UV damage, yep. accelerates wound healing. So again, it's a proliferation response, and so this is why this is such a huge market now with retinol. Does it work?
Yes.
It seems to. A lot of these topical treatments, you got to be careful because they are not lipophilic and they don't pass the epithelial border or the epidermal border very well. But this here is a fat soluble, so it actually crosses the membrane very well. So there's quite a bit of evidence now that this actually is improving skin tone. So that's the purpose of retinol and conversion into retinoic acid. Okay? So it drives gene expression, the retinoic acid. Now what else does it do? Well, again, we've got tissue-specific conversion. So in this particular cell, for vision, we have retinol coming in, and in this case, we are going to be converting this from the alcohol into the aldehyde and forming this little bugger right there. Retinaldehyde, aldehyde. And so this is our light vision. So the cis form binds to the rhodopsin, and then our transducin, which is our G protein molecule, is affected after light binds and causes a transconfiguration in the retinaldehyde. We get our G protein changes, we get hyperpolarization of the membrane, and we get neural transmission due to light, okay? So this portion here of this diagram is just to remind you of how the vision rod cell membrane works. It's not testable in the Ginny block, but just to integrate that. But the key information here is that we're taking the retinol that we're transporting and converting it in a tissue-specific manner to retinaldehyde, and then that retinaldehyde is used specifically for the rhodopsin activity. Okay. Questions on vitamin A? Okay, so again, where is the medicine on this? It's a transcription factor. It drives gene expression for cell proliferation and differentiation. It's involved in vision. So vitamin A deficiency, we could have problems with vision. So the retinol, patients will use that for skin treatment. For vision, people will take vitamin A and beta carotene to improve their vision, primarily through this mechanism to supply sufficient amount of that retinaldehyde. Okay? Yell out if I'm moving too fast. So vitamin C, ascorbic acid. So the classic one on vitamin C is involved in collagen basement membrane formation. So if there's problems with the collagen basement membrane, primarily that the cross-linking of those triple helical collagen structures is deficient, then we are going to have problems where the basement membrane is the most delicate. So a vitamin C deficiency is going to cause problems with collagen cross-linking activity throughout the body. But look at these tissues that are going to be most effective. Gums, lips, skin. That's the presentation of scurvy, primarily because these are very, very thin tissues with very small, delicate basement membrane structures. And so if there's going to be pathology, it's going to show up there first rather than on a thicker basement membrane. So what does vitamin C do? We have proline and lysine amino acids in our collagen molecule. In order for the triple helix of collagen to form, we have to do a hydroxylation reaction. And we're essentially going to be putting hydroxyl groups on these 2 amino acids. Now, after doing this, this is when the triple helix, the 3 individual polypeptides of collagen, are going to intertwine. So we need this hydroxylation for this triple helix to form, and then after that occurs is when cross-linking. And the cross-linking is simply mostly lysine residues that are deaminated, and we're creating aldehyde groups. And these aldehyde groups from the 2 different chains will cross-link, and this gives a nice, strong tensile structure of collagen. So if you have a deficiency in vitamin C, this hydroxylation reaction is going to be compromised. Are you still generating and synthesizing collagen?
Yes.
Sure, absolutely. You're still making collagen, but the triple helix formation is going to be compromised. And most importantly, if you don't have that, you won't have the cross-link. So if you don't have all of this, you have a basement membrane structure that is very weak, leading to epithelial problems on the surface of this basement membranes, leading to the ruptures and wounding, delayed wound healing, and pathology of the lips, gums, and skin, called scurvy. Okay? Yes?
When you talk about the collagen in the basement membrane, are you specifically talking about collagen 4?
Yeah. Primary, collagen 4 is the primary one, yes. Okay, so now what kind of question could I ask you on this? Will I ask you exactly where the hydroxylations are placed? No. I will ask you primarily about the clinical aspects of it and what process might be or vitamin might be deficient if you see this type of process. And here's the mechanism on it. Okay? So this is where I'm going with the vitamins. I'm trying to stay away from the world of all of this biochemistry, because this is overload for what you need. You need to know what the deficiency is going to cause and a little understanding of the mechanism of what's causing it.
Can you make your vignette a pirate who threw all his fruits overboard because he's an idiot? And then
I
present it to your office?
could make that vignette.
How about he threw all of his fruits at Rost?
I could do that.
Regardless, it'd be funny.
How about a somewhat of a vignette of like an old sailor comes to your clinic. He's been out to sea for a long time. He's lacking spinach, yeah. So that might be a possible vignette you might see on a summitum. Am I winking or what? An old pirate kind of thing? Not an old pirate, an old sailor. You know, crusty old sailor that's been out fishing for so long. Did I just give something away? But those are kind of clues that I might just give you to kind of lead your thinking into what the proper deficiency is. Okay, the other function of vitamin C is as an antioxidant. And this is primarily how much of vitamin C works. So vitamin C is required in those hydroxylation reactions. So in those hydroxylation reactions, there's a lot of redox chemistry going on, and it's the antioxidant function that is performing that in vitamin C. So what we're doing is we're taking this particular ketone, we're turning it into this alcohol, and then we're going back again to regenerate this process. So this is the function, the secondary function of vitamin C as an antioxidant. Linus Pauling. Remember that guy? Like 2 Nobel Prize winners. So, wow. I'm still trying to get my first one. What? So what he discovered was that vitamin C is very important as a flu remedy. So he takes enormous, tens of thousands of units of vitamin C, and it's primarily because he's exploiting this antioxidant function. Now, does it work?
No.
No.
Answer. It's true.
You're questioning a two-time Nobel Prize winner?
Yeah, the vitamin thing was crazy. There's a lot of Nobel Prize winners, come on. Not all of them have all great ideas.
Yeah, I know, but the vitamin C actually does have some protective effects because of the antioxidant. Now, whether it protects you against certain rhinoviruses or something, I don't know. I don't think that's been checked. But it does have protective effects. And so he did have less colds. Now, is that a proper control in there? No, probably not. So I think a lot of other research is going to go on. However, your patients will ask you, during cold season, should I take more vitamin C? Because I've heard it helps. And your response will be, knowing that thousands and thousands and thousands of units of vitamin C are harmless, what will your response be?
Why not?
Sure, why not? Exactly. Because you never want to discount the placebo effect. That's very powerful and actually overcomes some drug effects.
Right.
Okay, vitamin D. This is a big one, vitamin D, because this is going to spill nicely over into endocrinology. So we get vitamin D from two sources. The first source is 7-dehydrocholesterol. We make this. We make the 7-dehydrocholesterol. Now, that is of no value to us until we hit that cholesterol molecule with ultraviolet rays. Hence why we need a little time in the sunshine. That's going to convert that cholesterol into vitamin D3. And essentially, all this is breaking the ring. We're going to break the cholesterol ring very specifically, and we're going to generate a vitamin D3 structure. So remember I told you that cholesterol, once we make it, there's nothing we can do with it because we have to get rid of it because we can't break that ring structure?
You lied.
I lied. I'm sorry. Here we can break the ring structure to make vitamin D3. Now, an easier way to get vitamin D3 is this way, from our diet. We can take vitamin D3 orally and that can be absorbed. So, vitamin D3 is taken up. It binds to our vitamin D binding protein. And then is it active? Nope. It's got to go through a couple of different organs. So the first step is to take it, transport it to the liver. The liver is going to provide a hydroxylation, and that's going to be on the number 25 carbon of vitamin D3 is going to be a hydroxyl group. Still not active. The vitamin D3, 25 hydroxyl vitamin D3 goes now to the kidney. We get another hydroxylation reaction on the number 1 carbon. The 1 alpha simply means that it's in a down position in the ring. 1 alpha 25 dihydroxy vitamin D. Now this is the active form of vitamin D. So clinically what's important is that if you rely on an individual's endogenous synthesis of vitamin D3, they have to have some level of UV exposure in order to convert that into something that can become activated. Or it can be absorbed very. Now, parathyroid hormone does not work by itself. It can stimulate the kidney to increase the production of 125 dihydroxy vitamin D from the 25 hydroxy formed from the liver. So it can increase the expression of the 1 alpha hydroxylase to keep this reaction going so that we increase our level of vitamin D primarily because of a decrease in plasma calcium. Now, it's a coordinated action between parathyroid hormone and vitamin D that are able to restore calcium levels. So vitamin D doesn't do this alone, and parathyroid doesn't do it alone. Both of them are required to initiate bone resorption so that we can increase our calcium levels to take care of this problem of decreased plasma levels of calcium. So calcium phosphate is bone, so we're going to release calcium phosphate. So we're going to activate the osteoclast. So greater bone resorption, increased calcium. Now the other effect that this is going to have is on the kidney. We're going to decrease the calcium output in the tubules, and we're going to increase the calcium absorption in the renal tubules. And so this coordinated effect allows us to control our calcium levels inside the body. So we're going to excrete less, we're going to absorb more, and we're going to release it from bone. All of these activities are a combined effort between parathyroid hormone and dihydroxy vitamin D. Now, the last thing that this also does is right here. And this is important for patient care. The 125 dihydroxy vitamin D is going to increase calcium absorption by the intestine. Parathyroid hormone is not necessary for this reaction. So vitamin D alone can increase calcium influx from the lumen of the intestine. Why is that important for patient care? Dr. Burge has a whole lecture on bone metabolism. So this is kind of an entree to what he starts talking about. If you have a patient that is osteopenic or osteoporotic, you're going to want to increase their bone density. So in order to increase their bone density, you need to supply more of the matrix to generate bone, which means more calcium. So if you take out the intestine and you supply vitamin D to the individual, is this process here going to solve the osteoporotic situation? The whole reason for this is simply to control plasma calcium. This is actually counterproductive. You're actually increasing bone resorption, worsening the problem. So the vitamin D, what you're trying to do is increase the calcium absorption in the small intestine, increasing plasma calcium. So what's that going to do? That is going to decrease the amount of parathyroid hormone, because with elevated calcium levels, your sensing receptor now will shut down secretion. And if you have decreased parathyroid activity, the parathyroid and all that D3 that you've administered together will cause bone resorption. But without the parathyroid hormone, you will halt bone resorption. So the whole purpose of D3 administration plus calcium to your patients is to increase the calcium flow into the body so that your osteoblasts can increase bone formation and strengthen those bones. Yes?
Does increased PTH also act on the intestine?
No.
So
I don't know why that's up there.
So where it says increased PTH, does that mean you need both at the same time?
That's correct. PTH is not needed for increased calcium absorption by the intestine. D3 is all that's required.
Okay, but for bone resorption, is it both PTH and D3 are required?
Yes.
Or they both do that?
PTH and vitamin D are both needed for bone resorption and for renal activity, ultimately. So the PTH, combined PTH and vitamin D is going to control the tubule activity in calcium excretion, and calcium reabsorption. But for the intestine, just vitamin D. And simply, the reason for that is because if you take the intestine out of the equation, the parathyroid hormone and vitamin D circuitry is simply designed to control and regulate your plasma calcium levels. What you do as a physician is able to take advantage of this vitamin D isolated activity to increase calcium activity and uptake to increase the flux of calcium into the body. Okay? Now, what is the primary effect of vitamin D? Well, it's a fat-soluble vitamin, so it's going to perform a similar function in controlling gene expression as vitamin A. So here's our vitamin D, D3 from diet or sunlight activation. Here's our liver form, 25-hydroxyl, 125-dihydroxy in the kidney. This is going to pass into the cell cytoplasm. It's going to bind to its receptor, which is the vitamin D receptor. Vitamin D binding to this then binds to the retinoic X receptor. And then this together sits down on the promoter and changes gene expression. So you can imagine in the intestine, you're increasing the gene for calcium transport. So the primary mechanism that vitamin D affects is through gene transcription changes. Now, what's up with this RXR? Retinoic acid X receptor. What's vitamin A got to do with this? Have you noticed that RXR tends to show up a lot? So what this is primarily identified as is with your RAR, which is your retinoic acid receptor. The retinoic acid binds to RAR and then binds to RXR and drives vitamin A dependent genes. This RXR was identified as a transcriptional cofactor together with RAR. And so it was named retinoic acid primarily because they were co-associated in the identification. But RXR is a pleiotropic partner as a transcription factor. So it can also associate with vitamin D receptor. It can also associate with a whole bunch of other transcription factors that require ligand binding to them, and then they partner with RXR. So RXR tends to be kind of a common denominator, all of these. So this is not specific for retinoic acid. It was just originally discovered as co-associated. Okay. Vitamin E is easy. It's an electron scavenger. Its primary job is to be an antioxidant function. So I found this little cartoon that describes the various insults that we can suffer from oxidative damage. Smoking, air pollution. Here's your O3, your ozone conversion to free radical oxygen molecules. Inflammation from our inflammatory bursts. Mitochondrial action from the electron transport chain generates free radicals. UV light, radiation. So all of those, I call this aging, right? The longer you're on the planet, the more insults you have. And so how do we take care of this? Well, we saw one mechanism with our oxygen forming superoxide anions, and this is what we have to resolve. That's a free electron, that's an oxidative nightmare. So we have superoxide dismutase to form our peroxide. And then remember this, glutathione. So the glutathione is primarily used for neutralizing these hydroxide radicals, and we form that dimer of glutathione molecules. But remember, we have to resolve that dimer with the glutathione reductase, and in that case, we use NADPH. NADPH. I'm having difficulty today. Okay? So this process of glutathione is in all cells, primarily important in red blood cells, of course, but it's taking care of these free radicals. The other system that we have to take care of these free radicals is an enzyme called catalase, and that's also in all cells. So we have multiple ways of scavenging these free electrons to protect us from oxidative damage. But as we age, these systems start to decline. And so that means as we age, we need a supplement. And so vitamin E, which is also called alpha tocopherol, is a scavenger. It's a very powerful antioxidant effects. And so the sole purpose, but the major purpose of vitamin E consumption is to take care of this declining natural antioxidant activity. So this will help us stay young and is the fountain of youth to eternal life. Right? No, it gets us all in the end. Okay, questions on vitamin E? Okay, so here is our last vitamin, and it's a big one. Vitamin K. So vitamin K is primarily involved in the coagulation response. And what's important is knowing this particular mechanism, because the mechanism of vitamin K leads to an understanding of our clotting response, and more importantly for your careers, a deficiency in vitamin K. So here's what vitamin K does. It's simply a redox process. So this is a reduction, oxidation sequence of reactions. So we've seen a lot of redox reactions with NADH and NADPH. In this case, what we're going to do is we're going to substitute this redox reaction between these nucleotide molecules, and we're going to use vitamin K. So the reaction that we're interested in is taking our coagulation proteins, clotting proteins, part of our cascade, and these need to be prepared to undergo the activation that they need for the clotting response. This activation is a carboxylation reaction on glutamate residues. So what we're simply going to do is we're going to add another carboxyl group to this carbon on glutamate side chain to form this. Now, the enzyme that does this, gamma-glutamyl carboxylase, is going to require the movement of electrons. Because simply, these electrons right here need to come from somewhere. They're not being donated by the CO2 molecule. So this has to come from somewhere, and these two electrons right here are coming from vitamin K. So vitamin K in the reduced form is simply the carrier of electrons that is going to facilitate this carboxylation reaction of the clotting proteins. So vitamin K donates the electrons, and it turns into an oxidized form instead of its reduced form. Now again, like all good biochemical reactions, we have to come back to the beginning so we can keep the catalytic activity going. And so the next thing is the vitamin K reductase enzyme. And that enzyme is simply going to take the oxidized form of vitamin K, convert it into the reduced form. And we are going to use the electrons from NADH to donate to vitamin K to convert it back into its reduced form. Then we can keep this process going, and we can properly carboxylate all of our clotting factors. Okay? So that's the chemistry of vitamin K. Now, I've got this up here as just a reminder of a couple of our important end stage of our clotting reaction. If we have a vessel injury, that vessel injury is going to activate the conversion of prothrombin to thrombin, leading to platelet activation. The thrombin will cleave fibrinogen to fibrin. The fibrin lays down the clot. The activated platelets, platelet activation means primarily expression of GP2B3A, integrin receptor, which is going to bind fibrin, and you're going to form that nice platelet clot on there. This reaction here, this prothrombin to thrombin conversion, would not happen unless this carboxylation reaction occurs. So this is the end-stage protein that's involved, and vitamin K mediates its preparation. But we also have to do this with all of our other clotting proteins. Each one of these clotting factors needs to be processed for this carboxylation reaction to prime them for that catalytic activation sequence, okay? Now, I don't expect you to know all of this because this is hematology, that's a whole nother block. You've got all that down. But keep in mind that if you have a deficiency in vitamin K, a deficiency in vitamin K means that you can only do one round of this, vitamin K disappears, your carboxylation of these factors decreases. If that decreases, you become impaired in generating your clotting cascade. If that becomes compromised, that's going to lead to bleeding. So vitamin K deficiency by this mechanism increases bleeding by increasing clotting time. Okay? So, how do we measure clotting time? We can measure our prothrombin time. So you take some blood, throw in some thromboplastin and calcium in there to activate it, and then measure the time that the clot forms. And of course, there's a standard for that. So the PT method is the prothrombin time, and this will be an indicator of your clotting reactions. So if you have a deficiency in the carboxylation, the clotting is going to be compromised. And that's your first sign of a vitamin K deficiency. Now, what's the difference between PT and INR? What is INR? International Normalized Ratio. Okay, so it's no different than a PT, except you've normalized it to what is considered a mean normal value for the population for a PT measurement. And the sole function of this is the word normalized, so that you can compare these results from one lab to another, and one clinic to another, one hospital to another. Because, again, remembering, these are laboratory tests, and all laboratory tests will differ a little bit in between labs. So the INR is simply normalizing so that you can compare the value across different clinics. Okay? So vitamin K is essential for this clotting reaction. Because of this reaction here, vitamin K deficiency compromises the clotting pathway so that the clotting pathway is slowed. Now, what happens if you have a patient with atrial fibrillation?
Can't eat spinach.
Can't eat spinach?
No warfarin.
It's
Throw some warfarin at him. So what is atrial fibrillation?
It's when your atrium turns into jello.
That's very descriptive.
It works.
Yeah, it works, yeah. It just kind of, it vibrates, right? And so if the atrium vibrates, okay, I'm just pulling the basic science picture out of my head, right? If it's not really contracting properly, it's vibrating, it's really not doing the full push and contraction, what happens to the blood? Stasis, yeah. So you increase the potential for a clot. So how do you treat patients like that?
Give him a new heart.
Give them a new heart. Absolutely.
Give him a pacemaker.
Give them a pacemaker. What's a less expensive, less invasive way to treat a patient like that? Warfarin, yeah.
I like Adam's idea.
Give him a new heart. I like that better. We need artificial organs. So what is warfarin? What does warfarin do? It's very effective rat poison. If you put that stuff out, make sure you wash your hands carefully. So warfarin is an inhibitor of the vitamin K reductase enzyme. So if we inhibit vitamin K reductase, what we are blocking is the vitamin K oxidized form to going back to the vitamin K reduced form. Okay, so what we're doing here is we're slowing this reaction. And if we slow this reaction, we're going to slow this reaction, and this is the carboxylation of our clotting proteins. So overall, if we reduce this reductase activity, we're going to reduce the vitamin K activity, we're going to reduce the carboxylation of our clotting proteins. And what's going to happen to our prothrombin time? It's going to go up. So now why is this important to somebody with atrial fibrillation? You delay or try to prevent the problem of an embolism. Okay? So now, very important feature of warfarin. So if we measure an odds ratio of either stroke or a bleed. So this is what we're trying to control with warfarin. We're trying to prevent a stroke from atrial fibrillation, and we're trying to prevent going too far the other way and causing a bleed. So if we look at this, and we have we measure the INR, there's a specific range of INR that we want to keep all of ourselves. And so if we go below this INR, that means a decreased prothrombin time, and that means increase in stroke risk, because we're clotting too fast. So if we have an increase in INR, this is an increase in a bleed, because that means our clotting isn't happening fast enough. So fortunately, most of us spend our lives in this normal zone where we can balance the clotting reaction to take care of wounding needs, but we don't clot too fast, we don't clot fast enough. You get the picture, baby bear, mama bear, baby bear, just right in that region. So now, what is the purpose of warfarin? Warfarin is to keep us in this INR. So under atrial fibrillation, if we're here, we want to move ourselves back into here, which means that we want to decrease our clotting response. Decreasing our clotting response means the introduction of a clotting inhibitor, warfarin. So we're going to move in this direction. Now, if we give too much warfarin, we're going to end up over here. Okay, that's gone too far. So that could lead to a bleed, internal bleed. Now, the problem with warfarin is that the concentration of warfarin to keep us right here is very narrow. So the warfarin concentration to a patient needs to be adjusted very, very delicately. We're talking very small changes on the order of 1 milligram on dosages. And so this requires typically taking blood weekly. because you need to measure the INR of this individual on a weekly basis. If you give too much warfarin, you're going to go a little too far, so you cut that dosage back, check the INR, and make sure you're in the zone. If you go too far, you got to push it back. This window is very, very narrow. And so adjusting warfarin concentrations is a nightmare. I watched this with my dad. When he was diagnosed with atrial fibrillation, he called the nurse a vampire. Every week she came over to take some blood from him and measure his INR. And honestly, every week they were adjusting his medication from like 10 milligrams to 10.5 to 11 to 10.5 again. It's that narrow of a window to keep in there. So what is a better way to treat these types of patients? It's heparin, yeah. That'll do it. So what about some medications that target this process? Platelet activation. Yeah, now we get into baby aspirin. Okay, so that's our 81 milligrams of aspirin. And what we're designing there is something to not inhibit, but reduce platelet activation and platelet aggregation. And so by that method, we can control any type of stroke that might form through embolism. Okay? So now that gets us into icosanoids.